there was an injunction or there was a lawsuit against Pradaxa was that, remember, dabigatran was the first direct anticoagulant that came up on the market. So a lot of the advertising in the beginning did not really suggest that there could be bleeding with an anticoagulant, which is funny. Any blood-thinning drug will cause bleeding. And that is what really caused the legal troubles, not really because it's a bad drug. It just was advertised the wrong way. And I think that is something we should just try to explain to our patients if we think that's the right drug. And fortunately for us, this was a problem 2 years ago when that was the only drug we had. Now we have 4 choices. So you can bargain in some sense with the patient saying, which one of these would you feel most comfortable taking? Of course, that has to have some basis as to why we choose that particular drug. And again, just as a matter of disclosure, I have no interest in or financial interest in prescribing any one of these 4 medications, but as I look at the evidence behind these, I will try to suggest some medications which may probably be safer. And those are the 2 questions we'll answer. Are these medications safe and effective in the elderly? And why should we choose one drug over the other? Now, this particular paper, if you want to learn everything there is about the clinical data behind these medications, this is the one go-to paper you could look at. This is a meta-analysis where they pulled together data on all the 4 drugs that are approved for atrial fibrillation and lumped all this data together so that we can compare what these studies were like, what was the population included in the studies, and how effective these drugs were and how safe they were. So this meta-analysis published in The Lancet looked at all 4 of these drugs that are approved in the US market, and these are the name of the studies that were used to study that drug. So RELY was a trial that studied dabigatran. ROCKET AF is a study that studied rivaroxaban. Aristotle, apixaban, and ENGAGE TIMI-48 was edoxaban. Now, we're going to answer very simple questions from this table. The first thing we're going to answer is the fact that are these studies relevant to an elderly population? And right off the bat, you can see that in all of these studies, the mean age of enrollment was 71 years, which is pretty reasonable. If you're dealing with a geriatric population, you could say the mean age in this population is really relevant to my practice. And you see how a significant percent, almost 1/3 of patients in all of these studies were more than 75 years of age. So that is very important when you're looking at evidence for a drug. Is it relatable? Is this something I can use in my practice? Women made at least 1/3 of these studies, which is good. Like we already talked about how women can have more side effects from medications and stuff like that. So this is really good data. Now, since these studies were planned before we moved on to the CHADS-VAS score, what we have are the old CHADS score. Now, this is important because remember, when you enroll in a trial, you want to take patients that are representative of the population you would see in an average clinic in the United States. So you really don't want a study which had people with very, very low stroke risk. Because remember we said people who have a high stroke risk also have a high bleeding risk. So you may mask the bleeding effects if a trial enrolled only people with low risk. Now, fortunately, in most of these trials, you can see most patients had a CHADS score of more than 2, except the RELY trial with dabigatran. With dabigatran, you can see here that in these studies, about 30% of patients had a CHADS score of 0 to 1. They could still be a candidate for anticoagulation based on the CHADS-VAS score, but really it doesn't help us a whole lot. Now remember, if you see a population that's predominantly elderly, you're easily going to have a CHADS score of more than, or a CHADS-VAS score more than 2. So this was one of the problems with the RELY study, was the fact that there were not as many people with a high CHADS score. Now, if you look at the studies done on rivaroxaban and apixaban, you see how they seem to have a slightly higher concentration of higher risk. Okay? So this is very important to keep in mind. Now, as a group and between drugs, how effective are these medications in preventing stroke compared to warfarin? Now, these, I'll go through each. I don't expect you to remember the name of the study, so I'll say each drug as we go along. So this is what's called a forest plot. This gives us the risk of having a stroke if the plot is towards this side, the left-hand side. It means it favors the direct anticoagulant studied. If it is over to the right-hand side, it means that for that outcome in that study, warfarin was better. Okay? Now, if you look at it as a group, if you use any of these direct anticoagulants, as a group, they seem to reduce ischemic stroke better than warfarin. Okay? As a group. If you look at the individual drugs, you see how dabigatran seems to be the most effective, because the odds ratios, or if you look at the spread here and the relative risk reduction, dabigatran seems to do a whole lot better. Now, whenever you see that, you're going to go back and say, wait a minute, this was the study that had lower risk patients. The only other drug which actually showed benefit compared to warfarin was in Aristotle, the apixaban. Okay? So apixaban and dabigatran actually showed that they may be actually superior to warfarin, but the other two medications are at least as good as warfarin in studies which enrolled a pretty significant amount of elderly patients. So really, if you have an elderly patient, you do not have to worry that the medication you're giving is inferior to warfarin. You could use any of these medications. Now remember, if you go back here, apixaban and dabigatran are the ones which enrolled the most number of patients with a CHAD score that was low, meaning these were probably a little lower risk patients than in rivaroxaban or with edoxaban. So as a group, they're probably all, they're all probably as good as warfarin, if not better. So we answered that question. They're as effective as warfarin at least. Now, the most important thing is bleeding. If you put a patient on this medication, you're saying, boy, you don't need to get your INR checked anymore, you just take this medication, go home, you'll be fine. What about the risk of bleeding with these? Now, if you look at the forest plot here again, the left-hand side favors the newer drugs, the right-hand side favors warfarin, meaning that drug is better for preventing bleeding. If you look at it, all of these medications as a group combined are better than warfarin in reducing bleeding. They have less major bleeding. Now, most of that is because of apixaban and edoxaban. If you look at the trials that studied dabigatran and rivaroxaban, they were just the same as warfarin. Okay? So this is starting to make a little bit of sense, in the sense that I'm seeing this individual patient, the bleeding risk is high, maybe I need to choose one direct anticoagulant over the other. So this is important data for us to use clinically. Now, always remember, a patient enrolled in a clinical trial is never the same as a patient you'll see in the clinic. So individual results will vary when you use it in the clinic. And I think that's always something to keep in mind. But this is overall very reassuring data that the fact that you're giving a medication, there are no blood tests to check for how effective this medication is, does not increase major bleeding compared to warfarin, is very, very reassuring for providers and patients alike. Now, this is where it gets even more interesting as far as trying to choose the right medication for the right patient. This is, as a group, looking at individual problems that a patient can have, meaning not just bleeding as a whole, but how about if I looked at intracranial bleeding? How about if I looked at gastrointestinal bleeding? Okay? So let's start off from the efficacy part. Ischemic stroke, there was no significant difference, though it was favoring the the direct anticoagulants. As far as hemorrhagic stroke is concerned, remember we saw that table, that graph where we said warfarin has to be between 2 and 3. If you use the direct anticoagulant, you have a significant reduction in hemorrhagic stroke. Very important. So if you have a patient who you're worried about hemorrhagic stroke, you could preferably use a direct anticoagulant compared to warfarin. Now, who are these patients? Sometimes it's tough to delineate who would have a hemorrhagic stroke, just from a population basis. In our studies on warfarin, we found that Asian patients, people in Asia, have a high risk of hemorrhagic stroke on warfarin. This is really, the newer class of medications is literally a godsend, I think. If you have a patient who's of Asian lineage, I would preferably use a direct anticoagulant than use warfarin. Okay? So the risk of hemorrhagic stroke is significantly decreased with these new agents. Now, there was some concern that do these new medications cause heart attacks compared to warfarin? Usually when you have a new medication, that's always a worry. Really, they don't. They're as good as warfarin. Heart attacks have a different mechanism than strokes. And because of this reduction in hemorrhagic stroke, you see how when you pool all these studies together, you have a mortality benefit from being on a direct anticoagulant compared to warfarin. Okay? So this is the data we have so far, an exciting new class of drugs which promises to be as efficient, as good as warfarin, with a better safety profile if we choose our patients carefully. Now this is where I think things are most interesting. If you look at the type of bleeding events, intracranial hemorrhage we already talked about. The direct anticoagulants are by far safer than warfarin. What about this? Gastrointestinal bleeding. It looks like this is one area where warfarin seems to be more efficacious. Now, remember, this is when you look at all of these medications together. This I thought was an excellent little cartoon. I actually got this from an app on iTunes. And this is again goes to show how technology has made life so much simpler. Imagine, this costs like I think $2.99. But imagine having something like this where you could show a patient, involve them in this risk discussion to say, this is probably why you would be better off on this direct anticoagulant compared to the other. Now, this is what it shows. Okay, this can be a little confusing. We'll just spend time on this. So basically, instead of a chart which has an x-axis, y-axis, here we're looking at the y-axis showing fewer events. If it's above the line, it's fewer events. If it's below the line, it's more events. Okay? And then you have these different drugs, dabigatran, rivaroxaban, apixaban. Okay? This app has not updated it with edoxaban because the study that was published with edoxaban did not give as much data on these individual subsets. I assume that's why they could not. So let's look at this. All of these, if you look at the green, which is all-cause mortality, stroke, okay, all of these seem to have fewer events compared to warfarin. If they were worse than warfarin, these graphs would be going down. Okay, red is major bleeding. Okay, so if you look at the number of major bleeding episodes, there were still, fewer events with these medications. Now look at major gastrointestinal bleeding, which is blue. All of these medications except apixaban have higher gastrointestinal bleeding compared to warfarin. Okay, this is part of the reason why in my practice and many of my colleagues' practices, if you have an elderly patient who either had an episode of GI bleeding or is already on aspirin or clopidogrel for coronary artery disease, and you think they're already at a higher risk of GI bleeding, we tend to favor apixaban compared to the rest, just from a safety standpoint. Okay? So it's important to understand that we have choices, and probably based on a particular patient's individual risk profile, we could choose a medication. Okay? Now, what I have not gone into is, the drug dosages, the indications, contraindications, stuff like that. That's a topic on its own. But what I would with these few slides, what I wanted to convey is the fact that these medications are as effective as warfarin. Some of them have been shown to be superior. Safety-wise, they seem to provide a lot of reassurance. Let me address two questions I get all the time. One is, warfarin, patient comes in bleeding, I can give them vitamin K, I can give them fresh frozen plasma, I feel good. I've taken care of this bleeding. Now, if the patient's on a direct anticoagulant and they come in bleeding, I don't have an antidote, which is not true. We now have an antidote for it, at least the prothrombin complex concentrate is available in some hospitals. And now we have more targeted ones. But that is one of the common things patients always talk about. What if I was in a car accident and now no one can reverse it? People have looked at that. There are studies which have shown that the bleeding that people have on direct anticoagulants, if people bleed on warfarin versus if they bled on a direct anticoagulant, there seems to be no mortality difference, meaning these bleeds don't seem to be as severe compared to warfarin. That's one of the hypotheses as to why. So you can reassure people that, yep, this is something that's looked at. Even though there is there is reversal for warfarin, it doesn't seem to give it enough benefit for us to say, don't choose the direct anticoagulant. Remember, if you bled into the brain, I can reverse your warfarin as much as I want, but the damage probably is already done. So the hemorrhagic risk stroke seems to be driving the increased use of direct anticoagulants, and looking at the data, I think that's a reasonable conclusion for everybody to make. Now, as we talked about, some of these new medications 5 years down the road is when you know exactly what the real life situation is, but I think that's okay. As long as we're cautious, as long as we have a good risk-benefit discussion with the patient, I think it's reasonable to use these. So that's the number one question that we get with this. The second question we get with anticoagulation all the time is, in the elderly, my patient falls. He falls and falls and falls. He has atrial fibrillation and has a high stroke risk. What do? Is a fall enough reason not to do anticoagulation? Now, there have been a number of papers on this, and many people have a general understanding. There was this really interesting article that was published about 15 years ago, where they did a computer simulation. They added all this bunch of data in and asked the computer, knowing everything that we know about fall risk, bleeding risk, warfarin, this is only warfarin, not direct anticoagulants, how many times should a patient fall per year to where the fall risk becomes higher than having a stroke, meaning where the benefit of warfarin is outweighed by the risk of bleeding. And the number was something like 297 falls a year. Okay? Now remember, all falls are not the same, but just because someone's stumbling and falls a few times, that is no reason for us to say, or without, at least without a good discussion of the risks and benefits, for us as healthcare providers to just automatically remove the concept of anticoagulation from our mind. Because again, remember, high bleeding risk, high stroke risk. So always look at these patients saying, yeah, you fall, but you have a very high stroke risk. Would you rather take that risk or would you rather be on it? Because remember, it's a shared decision in most cases. Okay, let's get to the part which people find exciting all the time, and people always want to talk about it. As I introduce myself, I'm not a procedural guy. I don't feel like, even though I may do transesophageal echoes and stuff like that, I always have what I would like to think as a very pragmatic view of procedures as an antidote or as a cure. What is ablation for atrial fibrillation? You saw this cartoon already. Pulmonary veins, left atrium, abnormal impulses start there, they capture the entire atrium. So when you say atrial fibrillation ablation, what we do is we put in catheters in the femoral vein, thread these catheters up to the right atrium, make a hole in the septum, cross over to the left side, and literally have scars, burn scars around the pulmonary veins. So if you have any abnormal foci, they can fire, but they will not capture the atria because they go meet the scar and boom, they stop. Because that's electrically, that is inert. That won't let an impulse go through it. It's as crude as that. It's crude. Because what if the impulse comes from somewhere else? How many lines can we make? And there is a reason why I say it, because if you look at in the real world, not in centers that, not the Mayo Clinic, not Cleveland Clinic, just any hospital in the world. This is data from Europe, by the way, where they share medical data across centers much more than we do in the US, so they are able to come up with this. This is actually data from many hospitals across 20 countries in Europe, where actually the ablation started in France, so you can say they're probably a little bit ahead of the curve as far as ablation is concerned. These are the success rates of atrial fibrillation ablation. All comers, not elderly, okay? So if you look at 300 days, Kaplan-Meier curve, 300 days, say a year. If you have paroxysmal atrial fibrillation, you have about a 70% risk of success. If you have more persistent atrial fibrillation, the risk of success is 60%. All comers, young people, people with very well-defined disease, stuff like that. So really, this is not a cure for atrial fibrillation. And in fact, the electrophysiologists have realized this, and now they're using ablation for what I think is more appropriate, is to decrease the symptom burden rather than saying we are curing your atrial fibrillation. If you have 30 episodes of atrial fibrillation a month, which is really bothering a patient, which is causing them to go to the ER all the time, if you do ablation and reduce it to once, that is a meaningful result for a patient. This just goes to show that we need to choose patients very carefully while thinking of ablation for these patients. And remember, most of the elderly that we see in the clinics have non-paroxysmal, or they've been in atrial fibrillation for a long time. So the success rate is really low in those people. This is something we looked at. This was a large multi-institution group that studied this, and these are 4 of us from UAMS. We looked at complications of atrial fibrillation ablation across the country, across the United States. These were about 90,000 procedures. We used an administrative database to look at complications of ablation, because the way I made it sound, I hope I made it sound crude enough to realize that there can be complications when you're puncturing the transseptal, going in, burning the heart. And this graph you can say for pretty much any procedure, but I just want you to show that if you are an elderly patient undergoing ablation, the complication risk can be high. So you really have to choose a procedure which has a 10% complication risk. That's a significant number of complications. Now, granted, not all of these are death or anything bad, but you could have bleeding from the artery, you could have bleeding around the heart. So I think in the elderly, we need to be careful in thinking ablation is going to cure everything. Now, this is something that has become very popular. People think that this is, again, going to be the cure for all our ills. So we said thrombus formation is really the big problem with with atrial fibrillation. So this is a transesophageal echocardiogram. This is called the left atrial appendage. It's a vestigial organ. It's attached to the left atrium. That's where the blood flow is kind of the slowest. Obviously, wherever blood flow is slow, that's where thrombus can form. So that's how a thrombus looks like when we do a transesophageal echo. 90% of all clots in atrial fibrillation occur in that small area. They don't occur in this entire chamber, they occur in that small area. So geniuses, engineers, all of them got together and said, why don't we just close it off? Why don't we put a little device here, completely close it off? That's called left atrial appendage closure. And again, what happens? We go into the right side of the heart, we cross the septum, go over into that little appendage and put in a little plug-like device. And over the next 3 to 6 months, the body will form thrombus, will form endothelium over it, and completely close that left atrial appendage, reducing the risk of stroke. Not eliminating it, but reducing it. So this procedure has been shown to be as effective as warfarin. So it's now FDA approved, okay, with careful selection criteria. You can't just use it in everybody. These patients should have significant bleeding while on warfarin or some contraindication for anticoagulation. You could consider doing this procedure. The problem or the issue is twofold. One, it's not the holy grail by any means. Okay? Remember, if you have a patient who's bleeding and you put in this device, they still need to be on warfarin for 3 to 6 months till the device becomes endothelialized. If you don't put them on warfarin, that will actually become a bigger stroke risk because now you got metal or foreign object in the body. Okay? Now, I said warfarin because this device has never been studied with direct anticoagulants, so we just don't know. Okay? Now, how about thrombus formation in the rest of the atria? Something tells me that the body is not that stupid. Something tells me that if you close off that hole, the thrombogenic substrate probably is still there. I think if you follow these people long enough, they may still have strokes. They will probably still have strokes. So what I mean by that is we should really choose the patients we put this in very carefully. I don't think a 50-year-old who walks in, you know the type I'm talking about, who wants the latest, greatest procedure done. I don't think this is that kind of procedure. I think this should be reserved for very select patients, and no patient should be offered this saying, we're doing this so we can get you off a blood thinner for lifestyle reasons or whatever it is, okay? Now, what about in the current era of novel anticoagulants or direct anticoagulants, right? We said that the bleeding risk is lower, especially GI bleeding. Is the role really that much? I don't know. And of course, any procedure has complications, and that's something to think of. Now, if you have a patient that you would think would be a candidate for this is from the Boston Scientific website. They're the ones who make this device. Unfortunately, we are here in Little Rock. We don't have any center which implants this because the company is being very careful. They don't want everybody implanting it, causing procedural complications, which will then get them in trouble with the FDA. So they're rolling out very, very slowly. And we are hoping, at least at the VA, that we'll be able to offer this in the next year or so. Because we have a huge population that has a high bleeding risk who keep coming back to the hospital with bleeding, despite changing them to direct anticoagulant. So very small substrate. So if someone tells you, oh boy, I'm going to have my left atrial appendage closed, I think it would not be unfair for you to say, hold your horses. It's not really that great a procedure. Now, I had to put this in. As a non-invasive cardiologist, I believe that this is truly the holy grail of many diseases. Holy grail, not in it'll cure you, but it'll sure make you feel a whole lot better. The importance of a good lifestyle, healthy diet, adequate exercise. And this group was actually a group of electrophysiologists. I was very impressed when I saw this study. These electrophysiologists got patients with very symptomatic paroxysmal AFib, got them together, looked at their symptoms before, and then gave them 2 sessions of yoga a week. Did that for a few weeks, looked at their symptoms after yoga. Significant decrease in symptomatic and, more importantly, asymptomatic atrial fibrillation episodes, meaning you're actually changing the substrate. It's not just what the patient's feeling. It's not now the patient thinks they're better because they did yoga. You're actually changing something in the heart. And I think this is crucial. This, along with the slide we had on the heart age, I think is crucial in understanding that we can change the substrate with lifestyle measures more than we can with all the medications and the gizmos that we have. So if a patient of yours with atrial fibrillation wants to choose a healthy lifestyle, not just yoga, tai chi, what have you, I think we should encourage that. I think it will help patients who have atrial fibrillation. Quick word on a sister arrhythmia called atrial flutter. I said quick word because this is a situation which many people managing it in the primary care clinics can have a problem with, basically. Atrial flutter is different than fibrillation. In atrial flutter, there is a big, large, usually single circuit that captures the atria. Okay? When you look at the electrocardiogram, this is what you'll find. It's called the sawtooth pattern. It's very organized atrial activity. I said the atrial fibrillation is just fibrillating. It's just very irregular. Whereas this contracts in very fast, but it's still organized. It's doing this, it's not doing that, okay? So why do I say this is something that's important to look at in the clinic? If you have a patient like this, remember that the rate control with this can be a little tough, okay? When the heart is still beating fast but regularly, the AV node, which is like the traffic policeman in the heart, will let go of impulses at a certain rate. Okay, every 2 atrial flutter impulses, I let go of 1. Every 3, I let go of 1. Okay? So when you try to slow down the rate, you can have big drops in heart rate. You can go from 100 to 75. There may not be an 85 in between, because you can imagine this as almost a digital rhythm, 0 or 1, not an analog rhythm. So people can have a lot of trouble controlling the rate with this arrhythmia. So if you see atrial fibrillation, I think we should consider ablation in these cases. You should refer them to an electrophysiologist because unlike atrial flutter, unlike atrial fibrillation, the atrial flutter has a single circuit, and by applying burns in one area of the circuit here, you can eliminate the rhythm problem. Okay? So I just wanted to show this as to show how flutter is different from fibrillation. Now we talked about fast heart rates. A quick note on the slow heart rates, and this is again something that comes up all the time in the clinic, is my patient has a slow heart rate. What do I do about it? Now we talked about how the sinus node gets diseased as you go along in life. Most of the time, this is what you'll see. The patient will be fine. They come in, you check the pulse, it's a little low, you do an ECG, you find sinus bradycardia. And then the numbers start troubling people, just like they trouble people with atrial fibrillation. Oh, the number is 40, the number is 42. What should we do about it? And that generates a lot of consults, lots of tests. And I think it's important to remember again that if the rate is too low, the patient should be usually symptomatic. there is really no cutoff below which you'll say, oh boy, this definitely has to have something done for. Now remember, I'm talking about sinus bradycardia. Sometimes the sinus node not only just beats slowly, what happens is it could stop working altogether. You'll have a patient who is falling. You think it's a fall because they tripped or what have you. But what may happen is that there may be a period of time when their sinus node is just not working. And this would be very tough to capture on an electrocardiogram. Okay? And sometimes patients can have the worst of both worlds. They can have atrial fibrillation, something like this, and then when they convert back into sinus rhythm, the sinus node is just stunned. It's already old with age, it can't fire that often, and now the atrial fibrillation has acted more, and now you have these long episodes where there is no rhythm. Patients can pass out again. So I think when you're talking about a slow heart rate in the elderly, we need to be very clear as to, is the patient symptomatic, and how do we detect some of these? And really, I think the easiest way or the best way to distinguish these are twofold. Number one, walk the patient. If your resting heart rate is 40, but if you walk the patient in the clinic, it doesn't have to be a treadmill test, walk him in the clinic with a pulse oximeter on, which will give you the pulse rate, and if the heart rate goes up to 120, 130, you're done. You don't need to do anything for it if the patient is asymptomatic. Simple test in the clinic, which will give you the answer. The second most important thing, especially in people who fall, who have something like this, would be continuous ECG monitoring. Something like an event monitor, preferably an event monitor than a Holter monitor. A Holter monitor is only on for 24, 40 hours a day, at a time, so you may miss significant events. But I really think continuous ECG monitoring is the key here. So those two simple things will tell you which patient needs to be referred for a pacemaker or a device compared to others. And this is supported by the guidelines, and they're very clear. No matter what your sinus bradycardia is, if you're asymptomatic, it is not indicated. A class 3 indication in the cardiology literature and in most literature now is where you cause harm to a patient by doing a procedure. Okay? So if the patient's asymptomatic and you've shown that they don't have any pauses, they don't have any other evidence of sick sinus syndrome, you can just monitor the patient. Okay? And most importantly, we need to look at drug therapy that can cause lower heart rates, especially drug therapy that is non-essential. Okay? You won't believe the number of times we get a consult for sinus bradycardia. We stopped all AV nodal blockers, but wait a minute, they're on an intraocular beta blocker for glaucoma. Now that may be essential, and that's okay, but if it's really not and the ophthalmologist can find something else, that would work. Some people, they're on tizanidine, not as much in the elderly, but you'd be surprised what some elderly get for pain or muscle spasms. Tizanidine or Zanaflex, it's essentially a clone of clonidine, which is a well-known, antiadrenergic agent, which can cause bradycardia. So that is non-essential therapy. And looking at the medication list, working with a pharmacist, getting rid of medications that can lower the heart rate would be the way to go. So as far as sinus bradycardia is concerned, always correlate with symptoms. Do a symptom-limited functional capacity assessment. Just walk them in the clinic. If you have trouble with that setup, just send them for a plain treadmill ECG, and you'll know how the heart rate picks up. Continuous ECG monitoring, especially in patients who fall, I would highly recommend it. And there are studies to show this as well, that it's cost effective. If you have, not all falls are equal. If you have a clear reason for a fall, that's okay. But if you have unexplained falls, I think it's worthwhile to do something which is treatable or fixable, in other words, and always remove offending agents. And going along with the theme of this presentation, any intervention that we do in the elderly is not innocuous. There are always complications. This is a patient who just had a pacemaker put in, and because we stick a needle in the vein that's right above the lung, sometimes we can puncture the lung. And now they have a pneumothorax, and now they'll need a tube put in to drain that or to treat that pneumothorax. This is something we see in the elderly. There is not as much subcutaneous tissue and muscle, and the nutritional status is poor. So when you put in a device, it can actually erode through the skin. So if they have poor nutritional status, we think many times we try to improve it, do what we can to make sure this doesn't happen. Because if the skin and the subcutaneous tissue are not strong enough, there is nothing to hold the device back. And we are seeing more and more cardiac complications from having wires in your heart. And we are realizing this more and more now. For example, when you put in a lead in the heart, it essentially crosses the tricuspid valve and sits in the right ventricle. So imagine a valve that's made for nicely opening and closing. That's what the valve is supposed to do. Now you have a wire holding that valve open this way. And over time, that wire is going to get closer and closer to the heart because fibrosis is happening around the wire. What you have is tricuspid regurgitation. Patients can have swelling in the liver, edema, and now you've given heart failure to the patient. And now we also know that just pacing a patient against their own natural rhythm can actually cause congestive heart failure. All the more reason why I think we should be judicious in our use of pacing to treat bradyarrhythmias. So in this quick whirlwind kind of talk, I hope to have achieved the following goals here. I think we realize that cardiac arrhythmias are common in the aging heart. I think we realize that there are so many pathophysiological changes that happen in the aging heart that cause these, that truly there may not be a simple solution for some of these. I think it requires a coordinated approach. If you have bradyarrhythmias, I would highly recommend, rather than working on a single lab or a single test result, to do functional testing, walk the patient, look at the ECG, do continuous ECG monitoring. And I think especially in the elderly, we should carefully balance the risks of our interventions to the proposed benefits. If something has a good risk-benefit ratio, I think we should do it. In fact, atrial flutter, which I told you that can be easily ablated, we've done that in 90, 91-year-olds because they were so hard to rate control. And it's successful 95 to 98% of the time. So, and we don't have to cross over into the left heart most of the time. So I think those would be a few key points I'd like to add. And at this point, I thank you for your attention, and I'll be open for any questions.
I have a couple questions as a physical therapist, actually. And one is with regards to the stroke risk, not treating the rhythm, regardless of the anticoagulation. And the second one is in AFib patients who aren't being rate treated or potentially rhythm treated, their rates with activity. Any specific guidelines with those things?
Got it. So as far as the first question is concerned, I think it pertains to what is the stroke risk in a patient who is in atrial fibrillation all the time compared to going into atrial fibrillation on and off? Is that kind of the question of the first part?
The ones that you decide are appropriate to not rhythm treat.
Right. So studies have shown, at least in the AFFIRM study, that whether you rhythm treat or rate treat, the risk of stroke is approximately the same. Okay? Because a lot of patients have asymptomatic atrial fibrillation episodes. So they may say, oh boy, you put me on this medication, I don't feel my AFib anymore. Okay? But they could still be having asymptomatic atrial fibrillation, which puts them at a risk for stroke. So we really need to kind of move these two things separately. The rate and rhythm control issue is separate from the anticoagulation. Let me tell you what I would do if I had atrial fibrillation. Okay? No matter what anyone does to me, ablate, do any medication, I'm not going to stop my blood thinner a single day of my life. Okay? Because, and that's supported by data showing that there are so many episodes of asymptomatic atrial fibrillation that unless you're really, really sure with prolonged follow-up that the patient's staying in sinus rhythm, that we not stop an anticoagulation. So it goes to the same thing. If you think their stroke risk is if their stroke risk is high but their bleeding risk is higher, you would just talk to the patient and say, you know, whether you stay in normal rhythm or not, your stroke risk is the same. I would not do anything extraordinary to keep you in sinus rhythm. Because again, the same patients who have a high bleeding risk, their heart is also remodeled enough that it's really tough to keep them in sinus rhythm. So to make the long story short, what we're saying is the rate and rhythm control issue should really not be decided based on taking a patient off of anticoagulation, okay, in atrial fibrillation. Now the second part, if you look at the strict rate control, we had a guideline. We said, okay, with activity, if your heart rate's less than 110 beats per minute, it's okay. Now, we know that especially in the elderly, it's, you know, it can sometimes tough to control the rate. So now what most people do is if at rest their heart rate is less than 110, and when they go through physical therapy or any kind of therapy, if they're doing fine and their heart rate goes to 150, and if they're asymptomatic, it's still appropriate to continue the therapy, continue the exercise, and then maybe slowly up-titrate the medication later on. That by itself would not be an indication to stop therapy. There is no heart rate limit that should really make anyone stop therapy. We have plenty of people who are walking, their heart rate goes up to 160 or so, but they're fine. So we just do it on a slow graded manner rather than doing it with activity. Now, the medication we use to control the heart rate is also very important. We talked about 3 beta blockers, calcium channel blockers, and digoxin. Digoxin is the only medication of these 3 which will decrease the resting heart rate but will not affect the heart rate with activity. So if you see a patient who is in that situation where with therapy their heart rate goes up high, they're only on digoxin, the logical thing to do would be to switch them from digoxin to a beta blocker or a calcium channel blocker. Okay? So really no single heart rate with exercise that would preclude a patient from getting therapy. That's the thinking right now.
Thank you.
Yeah. Who knows, in 4 years there could be a study coming out saying that we're all very wrong here. At that point, we'll just delete this section from the DVD.